So we'll start in a minute. Kiran sir, can we start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the National Guidelines for HIV Care and Treatment 2021. Today's topic is management of sexually transmitted infections and reproductive tract infections in PLHIV. And the speakers are Dr. A.K. Puri sir from NACO and Dr. T.L.N. Prasad sir, who is the STAG member for SEARO WHO. We welcome you both for today's session. I now request Puri sir for opening remarks.
Good afternoon, everybody. Dear friends, this is a very important topic, STI and RTI. As you know that HIV is also one of the STI, it's a sexually transmitted infection. But in this context, we are talking about other STI and RTIs. But why they are important in the context of HIV? Because if a person is suffering from STI and RTI, his chances of transmitting infection increases many folds, and he can also get the infection. If a person is suffering from infection, he may acquire the infection also. Chances of acquiring is also increases, and if he himself is a PLHIV, he can also to his partner, his or her partner. So that is why it is very important. And although recent survey is not done, a survey about the STI RTI was done long back, wherein it was found that 5 to 6% of the population is of the adult population is suffering from at any given point. I mean, so that way 30 to 35 million people, they are having episodes are there every year. Episode of STI RTI are there in India. So such the infection is huge. And if we talk about the common infection, common infection are syphilis, gonorrhea, trichomonas, and chlamydia. And besides that, nowadays the bacterial infections are going down, but viral infections are coming up, are increasing. So why we have this? Due to the unprotected sex. So we always try to promote condom as far as possible. And condom will protect you from STI, from pregnancy, from HIV, from STI, RTI. So I mean, like these have got many. Benefits. So we should try to promote as much as possible, and we should give the correct knowledge, demonstrate the condom demonstration model should also be there with our counselor, and it should be encouraged. Generally, it is seen that the female counselors are they are not able to demonstrate it properly. So it is that is their limitation. But generally, they need to. They should be encouraged to talk about it. because it is a part of their job, and it will be helpful to the to the to the people with whom they are dealing with in the ICTC, in the ART centers. So we have to, uh, I mean, like, uh, promote and demonstrate about the condom as much as possible. So how we can, besides that, it may be STI RTI may be transmitted to the newborn from their parents. Uh, it may also be transmitted by the unsterile medical instruments. So, so it is very important to to protect a person from the STI RTI. So, how we can treat it by the laboratory investigations or by the syndromic case management. Syndromic case management is generally based on the uh, symptoms. Various symptoms are there, like uh, it is based on a certain urethral discharge, cervical discharge, ulcer, herpetic and non-herpetic, uh, uh, this thing. It may be their lower abdominal pain, inguinal and vivo and no genital warts and molluscum contagiosum. Uh, in addition to that, we will also be talking about the uh, STI RTI prevention objective and the role of male circumcision and the prevention of HIV transmission. So now it is over from my side. I invite the Dr. TLN Prasad for the for further to take it forward. Thank you. Thank
Thank you,
over
sir.
from my side.
Dr. Prasad, sir, can we quickly run the pre-test first? Sir, I think your audio is not connected. Can you please log in again? Participants are requested to kindly bear with the delay. Kiran sir, can we have the pre-test by then? Give me a moment. Prasad sir, can you unmute your mic, please?
Can we run the pretest, ma'am?
Kiran sir, please confirm if the pre-test has started. Yes. The pre-test questions are now visible on your screen. All the participants are requested to please attempt the pre-test poll. There are 4 questions in all. Please scroll through the questions and answer all the 4 questions. Kindly note the pre-test and the post-test questions or the questionnaire are linked to your attendance. So please remain with us till the end of the session for post-test also. Prasad sir, can you please try to unmute your mic?
Hello. Hello.
Yes, sir.
Are you able to hear you?
Yes, yes.
Okay. Then I think there is some issue with my laptop. And it is not able to. So, okay. If the poll is done, shall we start?
Poll is launched right now.
Okay. So can I have the first slide, please? Better?
Sir, 2 minutes, sir.
Yeah. So in the meantime, before I get connected, very good afternoon to all of you. And once again, a warm welcome for this NDLS session. Thank you very much for all of you for joining this important show. Some of you might be thinking, STI is such a old issue. Is it really important in the current period? Do we really need to discuss about them? Now, as we finish off this session, you'll understand why it is still important. And again, going back by what Puri sir has already said, and HIV is also an STI, and STI is also one of the key driver for the HIV epidemic. And not only that, it also gives us an early warning indicator, areas where we need to focus and strengthen our intervention so that the HIV spread can be minimized and can be controlled. Now, I think with this objective, we should able to understand again, and then I'll be more than happy to take questions if there is anything you have got. Please don't hesitate. You can put it in the chat box. At the end of the presentation, we can discuss. Or in between also, if you want, we can raise the hand and we can discuss. So now, as Shweta has already said that no, today's session is about management of STIs and RTI among people living with HIV. So when you see this title, some of you may get a doubt. Will there be a difference of STI and RTI in PLHIV than the non-PLHIV? Definitely no. It is the same kind of STI and RTI we see, but then probably there is a altered presentation and a different way of management, at least for some of the STI. And also there is an interaction between the ART and the STI natural course, so that will be an important point we need to understand in reference to the PLHIV. Next slide, please. Next slide, please.
Shweta ma'am.
Yeah, next slide.
So give me a second, please.
Yeah. Right. Now this today's session has got the following components. One is we'll have an introduction about the topic. Then we'll try to understand what is the transmission relationship between STI, RTI, and HIV. And then we will have a quick review about the syndromic approach to treat the common STI-RTI syndrome, followed by a brief description about the common syndromes what we come across in the program in India. Next, please. The main reason why we are also talking about the STI-RTI because there is some of them has got a chance of increasing the acquiring and transmitting of the HIV to the extent of 3 to 10-fold for various reasons, which we will learn as we go forward. Next, please. Yeah. Now, across the world, the current latest data suggests that there are 340 million episodes of STI-RTI happening across the world. I'm sorry, it is only STI, not RTI. And the Indian program is the only program, to the extent I know, which takes care of the RTIs also as part of the national program. WHO basically tracks 4 curable STIs. One is syphilis, second is gonorrhea, third is chlamydia. All these 3 are bacterial. And the last one is the protozoal, that is the trichomoniasis. And then, the data from the STI-RTI control and prevention program suggests there is a significant decline of these bacterial STIs, such as syphilis, gonorrhea, and chancroid, and not only in India and across the world. With some, with no uniformity, there is a heterogeneous way of, presentation of these infection. Then there is an increasing viral STA. Probably, we are able to identify them much more better and much more efficiently than earlier, which includes the herpes, both simplex and progenitalis, genital warts. There is human papillomavirus, molluscum contagiosum, hepatitis B, and then as far as trichomoniasis is concerned, it is an STI caused by a protozoa. There is no improvement or either increase or decrease of its prevalence. It is more or less standing around 3 to 5% for the last 7 decades, at least as far as India is concerned, and for reasons not understood by us. And apart from that, there is also a significant burden of the lower reproductive tract infection, especially in the women, with reference to bacterial vaginosis and candidiasis, and in a huge reason. And one of the main reasons for their highest prevalence is because of the poor menstrual hygiene, genital hygiene, and coital hygiene. And some of the RTIs and STIs increase, as we said earlier, the risk of acquiring and transmitting the HIV from 3 to many fold. Next, please. Now, if you look into the transmission or acquisition of the STIs and then the reproductive tract infection, STIs usually get acquired from an infected partner. So without an infected partner, they may not be, one cannot get infected with STI. And this infection may transmit either from the phenovaginal sex or anorectal sex, or is it ano-oral sex, or it is a kind of a what do you call even they are seen in the transgenders, that is male to male sexual forms also. It basically occurs on unprotected sexual forms, whether it is vaginal, anal, oral. And again, from an infected parent to newborn, either during the pregnancy or during the delivery or post-delivery through the breastfeed, it is the infection can spread. And again, by using the unsterilized medical equipment or transfusion of the untested blood and blood products, HIV gets transmitted from an infected person to an uninfected person. Here, there is one word which I want to emphasize. There is something called a superinfection. Superinfection means a person is already infected with HIV. He may again superinfected with another strain or another clade of HIV, in spite of having a infection already inside the bodies, which we usually don't see with other STIs. Whereas with reference to the reproductive tract infection, it is mostly due to poor genital or menstrual or coital hygiene, and are wearing the nylon underpanties or improperly dried undergarments, or medical procedures with unsterilized equipment, and or if the physician inserting something like an IUCD without a proper infection control measures, or whenever there is an illegal abortion activities taking place, then the woman will get ended up with the reproductive infection. Now, whether it is an STI or RTA, largely the symptoms and signs are located in the reproductive area. Hence, all STIs are RTIs, but all RTIs are not STIs. This discrimination, this differentiation is very important to avoid the stigma and discrimination, especially with reference to the unmarried and adults. Next, please. Now, as we have already discussed about the transmission, RTI usually are not transmissible. Please remember the word usually. They are not transmissible to partners, whereas STIs usually get transmitted. That is one issue. And then as already has been said, all STI can be said to be RTA, but not all RTA are not STI. Asymptomatic clients can have STI and also can transmit them to their partners. And then STIs are transferred more from men to women than women to men because of the larger surface area what women has got, the vaginal area, and as a result leading to the longer contact period between the etiological agents and the host. Next, please. So, what is the relationship between STI, RTA, and HIV? With this, we already said that there is a cofactor effect on HIV acquisition and transmission. HIV infection is predominantly a sexually transmitted infection. Presence of STI or RTA increases the risk of HIV acquisition and transmission due to loss of epithelial integrity, recruitment and activation of the inflammatory cells, and immune dysregulation. Now, these are the reasons why the STIs or RTAs increase the risk of HIV acquisition if they are not infected or already infected a superinfection, and if they're already infected, transmission to the uninfected person. Now, STI-RTA in HIV positive people can increase viral load. Now, we all know that any individual PLHIV with a high viral load is an efficient transmitter and can transmit to others. And that is the reason we don't see all children born to the HIV positive pregnant women have the HIV. And similarly, all HIV positive spouses will be transferring the infection to their partners. So it all depends on the key driver or determinant is what is the quantum of virus present in this individual. So higher viral load increases efficiency of HIV transmission to others. This is what made the statement which has come out, U is equal to U, undetectable viremia is equal to untransmissible virus. So if you want to achieve the ending of the HIV/AIDS as a public health problem, one of the important things what we need to do is identify every HIV infected individual and put them on highly effective antiretroviral therapy so that the viral load can be controlled, can be brought down to less than 200, a target not detected. And from these people, the chances of infection transmission to others is absolutely minimal. Next, please. Now, the same thing, we are also showing, in this diagram, is saying that the primary reason is the individual having a high-risk behavior, predisposes in acquiring either HIV or other STIs or both, and it also increases the transmission and progression to the clinical disease from the asymptomatic to the symptomatic. Both HIV will cause impaired immunity, which affects the frequency, the natural history, and susceptibility in acquiring the STIs, as we initially discussed. The clinical presentation may be different, but basically the same STIs, RTIs, what we see in non-HIV infected population, we see them in the PLHIVs also, only with a difference in the presentation part. Next, please. So what is the impact of STA and HIV? That is the viral load, the HIV viral load. Now, here is a small study which was done some long back, which says that urethral HIV DNA more than doubled when there was also the presence of STA, like an example, gonorrhea. However, treatment of gonorrhea cuts the urethral HIV DNA to half, almost the same as those without STA. The average effect of STA co-infection on HIV viral load in individuals on ART is minimal. So this is a very good point, and we need to emphasize this, and we have to counsel this with all the PLHIV coming to ART center, and thus unlikely to decrease the effectiveness of treatment as prevention. Now, TASP is also one of the strategy to control the HIV spread, and this is what is popularly known as TASP, treatment as prevention. However, there is not enough data to rule out the possibility that particular STI pose a larger threat. Now, if you see, look into if there is no gonorrhea, what will be the genital viral load? It is 19%. So please remember, this is the viral load what we are seeing in the genital mucosa and submucosa, not in the blood. Gonorrhea in pre-treatment stage, the genital viral load will be around 44%, and the gonorrhea post-treatment, it comes down to 21%. It is as good as having half of the decline will happen. As a result, the transmission risk will be minimized. So the point here is, whenever we do a viral load test, we are testing the blood, not the genital fluids. When we are testing the blood, we will get the result, no, either the viral load is more than 1,000, viral load is less than 1,000, or viral load is not detectable, and that's what is called target not detected. This speaks about the virus quantum in the blood, not in the genital fluid. There is still a possibility that the virus will present in the genital mucosa and submucosal level. That itself can also cause transmission risk to the uninfected partner. So this has to be kept in mind. So repeated counseling about consistent and correct use of condom, not reverting back to the risky sexual behavior, is what needs to happen at every interaction with PLHIV, at ART center, in drop-in center, and in the networks also. Next, please. So what are the common symptoms and signs of STI, RTI in women? Now, this we all know, but still for the sake of the session, let us quickly go through them. What are they? Most importantly, what we see is either excessive or abnormal discharge from the vagina. When we say abnormal, it will be a change in the color, change in the consistency, or odor, which is usually not present. So these are the first and foremost commonest symptoms and signs what we see in a woman with STI, RTI. Then there could be itching, rash, or it can be sores or blisters in and around genitalia, or perianal or oropharynx area, depending on the type of sexual behavior the individual had or practicing. Then there could be swellings in the groin and in the vaginal area, and it could be because of the etiological agents themselves, or it could be due to the lymphadenopathy. Then if there is an infection in the pelvic tubes, then it will may cause to the lower abdominal pain. Now, frequent urination is another thing, and there is also pain or burning while passing urine. Usually, we call this as external dysuria. Unlike in men, the woman doesn't have the anterior urethra. As a result, when the acidic urine falls on the inflamed vaginal tissue or the vulval tissue, it causes burning, and that is what we call it as a pain or a burning while passing the urine. So one need to pose this question, whether it is to differentiate between the external dysuria or is it associated with something other than that. Then pain while having sex is another important thing, especially if there is a source in the vaginal and anovaginal area, there will be dyspareunia. And then if there is a history or if there is a practice of oral sex, there is a possibility of sore throat with the throat irritation and mild cough. Next, please. Now, what are the symptoms, in the male? Now, first and foremost, I'm sorry, there is a vaginal discharge. Vaginal discharge is not seen in the male. Somehow, this vaginal discharge and cervical discharge. I think the slide itself is incorrect. Can we move to the next slide, please, Shweta? I think this slide is not corrected. Yeah. So the, next slide, please. This is incorrect
So
slide.
this was replaced.
Yeah, no, this is, we don't see these syndromes in male, or these are not the symptoms also. Can you please?
Yes, I'll take the next slide and
Yeah.
I'll get it corrected before circulation.
Yeah.
Thank you, sir.
So like in female, the common symptoms and signs in male are more or less similar. You see mostly, discharges from the urethra, anorectum, or oropharynx. Oropharynx area, the discharge will be very, very minimal, but usually it is a very inflamed, irritated, reddish pharyngeal mucosa, and it is usually due to the oral sex. And then there can be swellings in the groin and the genital area. There can be rashes around the genital area or anal area or oropharynx area. Frequency of urination and burning and while passing the urine. This is because there are the glands in the anterior urethra. This gets inflamed most commonly due to gonococcus and chlamydia trachomatis. So when the acidic urine passes through this inflamed glands will cause burning, and that will cause a very discomfort to the individual. Then you may actually see a discharge, which may be a pure first to zero sanguineous discharge coming from the urethra or from the anorectum area. And whereas when you look into the oropharynx, it looks very much inflamed, reddish, and sometimes we also see a small vesicular eruption on the posterior pharyngeal wall, and this causing mild irritation and a cough. So it is a sore throat. Usually the oropharyngeal STAs do not have any symptom unless until there is a HPV infection and there is a possibility of the growth we can see. Otherwise, largely it is asymptomatic unless until we have the history that the individual had a oral sex with a possible casual sexual partner or with someone who is likely to have a STA. This suspicion will not enter into the brain. But when we are testing, we test the samples from the oropharynx, anorectum, as well as from the genitalia. Next, please. So what are the most common syndromes we see in the men? As Puri sir has already said, in India, National AIDS Control Organization implements a syndromic case management to manage the commonly observed STI, both in men and women, both in the general population as well as in the bridge population and key population. So across the country, this is the common modality in managing the STI, which is practiced and adopted almost all for the last decade plus, and which has given an excellent result. And sometimes, I feel that it has acted as a carpet bombing and it has sanitized the population to a larger extent, decreasing very significantly the bacterial STIs. The most important syndrome out of all the syndrome is urethral discharge syndrome. The very reason why we call this as the most important, because urethral discharge syndrome is caused commonly due to gonorrhea, chlamydia, and sometimes it is mycoplasma genitalis, and also to trichomoniasis. The trichomoniasis as an etiological agent is very rarely isolated. There was only one study which found that in Karnataka. Otherwise, we usually see gonorrhea and chlamydia. No other reason is the gonorrhea, the incubation period is very short. It varies anywhere between 1 to 7 days. So, in other words, urethral discharge syndrome is or gonorrhea is a surrogate for incidence of the STI. So, whenever there is a high number of urethral discharge syndrome is reported from any particular geographic location, one needs to be get alarmed and then start. It's a kind of an early warning indicator that there is a possibility of impending HIV going to occur in that area, and the interventions need to be strengthened. So that is the point behind the urethral discharge. And another thing, whenever we see any STI or any STI syndrome, that indicates, number one, there was an infected person who has transmitted this infection to the individual whom we are seeing in our clinic. Second, this individual has not practiced a condom. It was an unprotected sex. Third, he or she may or may not be using used self-treatment or treatment from the private sector before they came to you, because you are able to see the discharge. So these are the three, indirect indications it is giving us whenever we see any STI syndrome, and especially the urethral discharge syndrome. Followed by the genital ulcer syndrome. This is a very common. And earlier we used to see chancroid, syphilis, donovanosis, lymphograngioma, venereum. But nowadays, most of these have been disappeared, and largely it is limited to the genital herpes. And after post-COVID, syphilis started emerging, and we are seeing a combination of syphilitic as well as herpetic ulcers. And remember, whenever you are diagnosing one particular syndrome, there is a 7 to 10% chance of presence of second STI in the same individual, maybe HIV, maybe something else. So please don't lose the opportunity of examining and diagnosing the hidden STI. And that's the reason the program always advises every STI clinic attendee should be screened for syphilis using the RPR test, so that we will able to detect asymptomatic syphilis, asymptomatic serological syphilis in the individual. Followed by inguinal BIVO syndrome. It is usually caused by the LGV and chancroid. Fortunately, LGV has come down to very minimal, and it is largely limited nowadays to the southern India and also interstate borders where the services are not that rapidly seen. And again, chancroid is also almost disappeared with the widespread use of the antibiotics. And as a result, we are not seeing them. So in case if you are able to see, then it can be, it's something which needs to be considered. And whenever we find an inguinal BIVO in either male or female, but usually limited to the males. Then scrotal swelling. Scrotal swelling is seen only in the males. Please remember, scrotum is not there in the female. So scrotal swelling should not be reported in females. And it is nothing but of a painful scrotal swelling, a complication of untreated or poorly treated gonorrhea and chlamydia, maybe mycoplasma genitals also. Second is anorectal discharge. It is commonly due to gonorrhea and chlamydia. The same discharge, which causes urethral, also will cause the anorectal discharge. Second is, throat irritation. Whenever if there is a oral sex is there, and then the throat may get infected with the gonococci, and it is what is called gonococcal pharyngitis, and also chlamydia can be one of the etiological agent. As we discussed earlier, the symptoms usually very mild, very minimal. It is only suspicion that gives us from the careful history what we have take, and then examination of the oropharynx. Then, the genital skin condition. These are the very commonly seen in large number and significant number. Most of you might have been seeing them in your clinics also. Here, most important is the HPV-induced warts, especially in the genital area, anorectal area, or oropharyngeal area also. Second is molluscum contagiosum. It is a fairly pearl-like lesion. And whenever you see a larger molluscum beyond 10 centimeters or facial molluscum, it is a surrogate marker of immune deficiency, and we suspect undetected HIV infection in the individual. Then pediculosis pubis is another, it indicates poverty, overcrowding, and and also decreased immunity and starvation and drought. These overcrowding, all these will encourage pediculosis pubis infection. And then genital scabies. In PLHIV, one important variety of scabies which is observed is Norwegian scabies, or otherwise called crusted scabies. Crusted scabies is highly infectious, and you find millions of itch mites under each of the plaques. We can see that, and fortunately, it is easy to treat. But one should have the suspicion that usually the people make a diagnosis of psoriasis because it mimics psoriasis. But please be careful and then try to see and take out one of the scale and see under the microscope. You will be surprised to see hundreds of itch mites under these mites. And surprisingly, these people don't have the itching. That's the most common thing what scabies have. But these people don't have itching. Probably it is masked because of the altered immunity in the PLHIV. Still, we are seeing the Norwegian scabies, mostly in the northern India and sometimes in southern India also. And once upon a time, it used to be very widely reported from the care support centers. Fortunately, now it has come to a very minimal. And ART is definitely improves the situation and also gives a miraculous recovery and cure. Next, please. Now, these are the, how do we manage the STI-RTS syndromes? Now, most of you must have seen these color-coded kits, which are being introduced by the National AIDS Control Organization. They were in use for the last 10 to 12 years, and they were a great success. And they have been, what do you call, they cover wide spectrum, and then it eliminates the need and necessity to do different investigations and it also offers you the chance of giving treatment as the first contact, what we call as the DOTS treatment, a directly observed treatment at your chamber in front of you, so that the adherence is almost 100%, and which minimizes the emergence of the drug resistance. So for the urethral discharge syndrome, we administer kit 1, that is a gray colored kit. It contains 1 gram of azithromycin and 400 milligram of cetirizine. Both need to be taken statum, irrespective of on empty stomach or after eating, and after administering nearly more than 2 million doses, we have not seen a significant side effects with this administration in the clinic premises. So, but it gives you the advantage that the patient has taken the drug, and then there is a possibility of emergence of drug-resistant gonococci will very is minimized, and there is 100% adherence is ensured in front of us. So, kit 1 is not only used in the urethral discharge syndrome, it is also used in cervical discharge syndrome. It is also used in the painful scrotal swelling syndrome, as well as it is used in the presumptive treatment for the key population. Presumptive treatment is for those people who are having a higher chance of acquiring or having gonococci or chlamydia, are offered treatment irrespective of they having symptom or sign when they come first time to the STA clinic. This is what is called a presumptive treatment. Now, presumptive treatment, as the name suggests, is a presumption of the program that these people may be infected, even though we are not able to demonstrate, even though the individual do not have any symptom or sign, we administer this and we repeat the kit 1 after 6 months of gap if the individual do not turn up to us and remain still asymptomatic because they were into the field of or occupation of a high risk of encountering, on an average, 1 to 3 clients a day, 20 days in a month, there is a possibility that they may be having this infection. And that's the reason we repeat again the kit 1. Now, the kit 1 is also being used in painful scrotal swelling syndrome. As a result, earlier we used to have a black color. Now that has been replaced with the kit 1. And whether this guideline has reached to all of you or not is I'm not aware. But then this can be used for this. And then also it can be used in the inguinal BIBO syndrome, because inguinal BIBO, as we discussed, it is largely disappeared. So over treatment, or earlier the treatment we used to suggest is about 2 weeks. So that's a lengthy course of treatment. So the experts have suggested that it need not be, and the kit 1 itself can be given if it gives the clinical resolution, or if the clinical resolution is not coming and if the clinical suspicion is still continuing, then probably you can go with the standard treatment to control the inguinal BIBO syndrome. Next slide, please. Now, sorry, can you please go back, Sweta? There is one more important kit, that is the green colored kit. This we use to treat the vaginal discharge syndrome. This is very popular in the gynae department, because 1/5 of the gynae OPD is because of the discharge from the vagina. And and most of them, they thought that no, this is a very useful supplement for them. Unfortunately, they think that it alleviates or minimizes their need to do speculum examination, because out of every 100 women, if 20 are having vaginal discharge, and if every one of them require speculum examination, one, to have the adequate turnout of the sterilized speculums is a big limiting factor. Secondly, the larger number of the OPD, which needs to be completed within the short time, is another factor which makes the healthcare provider to administer kit 2, usually by asking the question and popping the pill. And unfortunately, that is not a syndromic case management. Next, please. Now, the kit 3 and kit 4, kit 3 is a white colored kit, kit 4 is a blue colored kit. This we usually administer to the genital ulcer syndrome, non-herpetic, which otherwise bacterial genital ulcers. The kit 3 contains injection benzathine penicillin, having 2.4 million international units, 1 vial, with 1 gram of azithromycin. Now, this benzathine penicillin has to be given deep intramuscular in the buttock. Ideally, it should be given in the facility where you can manage anaphylaxis. And the evidence suggests that anaphylaxis to benzathine penicillin is almost non-existent. There is only one study which reported 7 cases in Israeli recruits, army recruits, and other than that, there was no proof. And we have published one paper in the Lancet. We have administered more than 1 million doses of benzathine penicillin across 6 high prevalent states. We haven't come across a single case of anaphylaxis. So my request to all of you is, Please don't be afraid of anaphylaxis. It is extremely rare phenomena to benzyl penicillin. It usually happens with procaine penicillin. Crystalline penicillin, benzyl penicillin, usually they do not give anaphylactic reaction. That has to be kept in mind. But nevertheless, it is the human life that is at the stake. Better to administer penicillin and penicillin analogs in a setup where you have got a basic life support system. And after administering the injection, it is better to keep the individual for at least half an hour to 45 minutes so that any untoward reactions can be observed and managed effectively. Now, in the proof of definite allergic history in the past, or in there is a history of atopy, and which is very widely common in India because of the consanguineous marriages and all, then we go for kit 4. This kit 4 consists of doxycycline. If it is the initial infectious period, that is within the 2 years of the acquisition of the syphilis, then we administer doxycycline twice a day for 15 days, plus azithromycin 1 gram single dose in front of the provider at the facility itself. So this is the kit 4. Now then the kit 5. Kit 5 is the, or otherwise called a red colored kit. It is widely used to treat the herpes simplex and either primary or secondary, either recurrent cases. Now in a primary episode, we administer 400 mg acyclovir tablets 3 times a day for 7 days. And if it is a recurrent episodes, we administer this 1 tablet BD for a period of 6 months or till the episodes reduce to less than 6 over a period of 12 months. So both of them are advised in the program. Next is the yellow color kit or kit number 6. This we use to treat the complication of the poorly treated or improperly treated cervical discharge syndrome, which is commonly due to Neisseria gonorrhoeae and Chlamydia trachomatis. Along with that, there could be also non-STI pathogens which migrate from the lower genital tract through the endometrium to the pelvic tubes. Now, the kit consists of cefixime 400 mg. Single tablet should be administered in front of the provider in the clinic, followed by metronidazole 400 mg twice a day for 14 days, and doxycycline 100 mg twice a day for 14 days. Now, both metronidazole and doxycycline will cause gastric irritation and nauseating sensation. So, it is ideal to be taken after food, but we need to keep on counsel the individual that they should not ignore or forget to take because the duration is quite lengthy. We need to ensure that in every contact of the individual in the follow-up visits, we need to inquire that there is a strong adherence. So this is another point which we need to remember while managing the pelvic inflammatory disease. Then the last is the inguinal bibo. This we have already discussed. Earlier, we used to promote the black colored kit. It used to consist of azithromycin 1 gram, that to be given statum 1 tablet, and followed by doxycycline 1 tablet BD for 21 days. But later, the experts have suggested that this much lengthy duration of treatment is not required in the light that the cases are absolutely declined or probably eliminated, though we don't have the scientific evidence. So better to administer kit 1 for them, for the people who are diagnosed as the inguinal bibo syndrome. Next, please. Now, syndromic management, many of doctors, especially the skin and VD specialists, have a strong opposition against the syndromic case management because they all studied about the etiological management and they feel that the etiological management is the best course and it will also give us the absolute kind of a guarantee that the individual has been diagnosed properly and we are not over treating or not missing the correct case. But if you look into the syndromic management steps, you'll understand that this is a very comprehensive medical treatment. And then, there is a follow-up, which is, embedded within each syndrome that to make sure that the individual is progressing with reference to the symptoms and signs. And, it also, the STIs, as we said that, there is a possibility of them to transfer to the partners. So there is a partner treatment is also required. But whereas partner treatment is not necessary for the, for the RTS, usually, unless until the partner is found to be infected with the RTA, especially Candida. Candida balanitis is quite commonly seen. And then, so this is when there is a Candida balanitis, we need to give to the partner the treatment. Otherwise, no routine partner treatment like in STA is not necessary, except trichomoniasis. When you demonstrate trichomoniasis in either of the partner, the other partner need to be given, because STI, even though trichomoniasis is a protozoal, it is being considered as an STI. Henceforth, we need to give the partner treatment so that the people, the infection will not continue. So that is another point which we need to remember. And then and as we discussed that there is a chance of presence of another STI along with the presenting STI in about 7 to 10% of the cases. Henceforth, please pay attention, do examine, do screen them, and both for HIV and then syphilis, to detect possible hidden second STI. So if it is not there, it is good, but then all our efforts should be there with an assumption that they may be having this. So that is another point which we need to keep it in our mind. Then we have to counsel and educate the client on safer sexual practices. The reason we use the word safer, because there is no safe sex. It is only a safer sex. It is only a relative a phrase, not a absolute phrase. Henceforth, we always use the word safer sex. That is the best way of saying that, so that the patients also will understand that the whatever we are suggesting, that like for example, condom, consistent and correct usage of condom is not 100% preventive. It's still people do get STIs. These are what is called condom associated STIs. Henceforth, we need to say that you need to follow the safer sexual practices to the extent possible. Then risk reduction strategies. Risk reduction strategies means if the individual has got a multiple sexual partner behavior, and we try to encourage them and motivate them and counsel them to reduce or limit the sexual partners to one and not more than one. That too, a consistent partner is better than a casual partner. Then behavior modification. The behavior modification here in the sense is taking the substances like alcohol or drugs, which will negate the social inhibition and encourage them to take the risky components. So that is also can be that needs to be emphasized at every and each contact with the individual. Then we have to demonstrate condom usage, and then promote condom usage, and then provide condoms. So how many condoms we need to provide? We assume at least one encounter in a day, so that we will use, we will provide before they come for the follow-up, the number of condoms we will be giving. Next, please. Sweta, I am not seeing the slides. Yes. Yes, please. So these are the basic steps. Now, if you look into the same thing, what is the steps of the syndromic case management? This is the same thing has been kept in a step-over manner. So first it starts with history taking, followed by clinical examination. And if you all remember the Hutchinson's clinical methods, it says that unless until we examine the genitalia, oropharynx, and anorectum, the general examination is not complete. This he has quoted without reference to the STIs. So that means we need not forget those basic golden principles of the medicine, and that needs to be done. And then you will come out to the appropriate syndromic diagnosis. And then wherever there is a laboratory test are available, especially the syphilis screening and referring to the ICTC for HIV counseling and testing should be done. If they are not there, if they are not available at the given facility, we should not stop giving the treatment. And that is one advantage of the syndromic case management. And then then followed by this enables us early and effective treatment, so that so that it makes individual need not come again, and we don't lose the opportunity of the individual coming and accessing the service. Next slide, please. Next slide, please. Yeah. Now, as we discussed, we provide condoms, and then we counsel for behavior change, and then we refer to for syphilis screening and HIV counseling. And then then important point is partners notification management. Here, it is the duty of the treating physician to inform the partner, and then to also encourage the index case, motivate them to bring their partners. Unless until the partner is a casual partner, if the index case is married, the spouse need to be brought in for the examination, and then but that has to be done in a non-threatening manner, in a advocating manner, so that the individual understands the need for treatment. And and if it is not possible, and if you are sure that the patient has understood, then you can offer the treatment to him to be administered to his spouse. No, that also can be done, but then usually it has got a 50% success. However, best we try. Then follow up as per the schedule. And lastly, document all whatever has been done in the patient record so that it will be a proof to us, and also it will help us to understand the kind of progress the individual is having in the subsequent visits. Next, please. Now, what are the advantages of syndromic image management? Now, we already realized, it gives us the opportunity to treat most common etiological agents of a particular syndrome. It enables us to give a treatment at the first contact, and it does not need to wait for the laboratory test. Irrespective of you have the laboratory test availability or not, you can offer the treatment. And then it covers the entire spectrum of the STIs causing that particular syndrome in that particular geographic location. And then Government of India, National AIDS Control Organization has done studies, and then based upon those observations only these syndromes have been identified and the treatment regimes have been constituted. Henceforth, we are assured that we are covering all possible etiological agents. And then it is also proven a strategy to decrease, not only in India, not only in across the lower and middle income countries of the world, and then in many of the developed countries also, if there is no immediate availability of the etiological diagnosis, they resort to the syndromic case management. It can be implemented by anybody, by a specialist, by a non-specialist, by a healthcare worker, by a paramedic, and it does not require a specialist to be available. And most importantly, it helps the program to standardize the treatment across the region, across the country, so that a standardized treatment regime, the single advantage is it minimizes emergence of the drug resistance. As we know that gonococci, like in TB, we have drug resistant gonococci, extremely drug resistant gonococci, and multi-drug resistant gonococci. These are all very different kind of variants. And once they enter into a particular geographic territory, the entire scenario, the epidemiology of STI changes so rapidly, it is very difficult to control. Henceforth, it is always ideal to prevent this to happen. And syndromic case management helps us to do that. Next, please. But then at the same time, syndromic case management also has got certain limitations. One, we cannot give we cannot offer a syndromic case management as a mode of treating in an asymptomatic individual, because syndrome by definition is a combination of symptom and sign. When there is no symptom, not a sign, where is the question of application of implementing the syndromic case management? That is the biggest limitation. And nowadays, this is the greatest point, especially with reference to the key population, wherein many of them do not have any symptoms. And not only that, when the people who are coming to the STD clinics also, many of them don't have any symptoms, except in the gynae, the RTI related symptoms, we don't see them. So where is the question of applying the syndromic case management? So this is one of the major limitation. Second is there is a possibility of over treatment, because the symptom, maybe somebody may be coming and telling us he is having a discharge from the urethra. That may be a nocturnal emission, not related to any STI per se. And then the person may be having a myth or a misconcept that he touched some lady and as a result this is happening. So we think that even though it is not seen, the discharge is not seen visibly, we assume that it could be, and then we administer. And similarly in the key population also, we assume because of their high risk nature, we administer this as a presumptive treatment. In such situations, what happens, we are over treating, though the individual do not have the particular condition. So this is one possibility. So this over treatment, increases the cost of the treatment, cost of the management of the condition, and possibly emergence of the other side effects, and also has got a potential for development of the resistance to the antibiotics. And secondly, the syndromic case management, in different countries, it has given different levels of sensitivity and specificity. In India, when we have studied sensitivity and specificity, we found around 70 to 80% specificity and about 60 to 70% sensitivity, especially with reference to the vaginal discharge syndrome and cervical discharge syndrome. So these are the key and main limitations of the syndromic case management, but one need to keep in our mind. But nevertheless, syndromic case management still proved to be the most value add. The recent experiment done by the WHO, it proved that out of different modalities of managing the STI, RTI, syndromic case management still is the best choice to be practiced in any country. That is the evidence-based lesson what has been learned by the WHO. Next, please. Now let us see, individual syndromes. Quickly, we'll go through them. And urethral discharge syndrome. There is usually a history of unprotected sex within last 3 to 7 days before presenting to us with a purulent urethral discharge. The urethral discharge need not be purulent all the time. It can be purulent to serosanguinous to mucus. So it depends on the virulence of the causative organism and also the immunity of the individual. It depends about that. And the usual etiological agents is gonorrhea and chlamydia. It has got the shortest incubation period as we consider that 1 to 7 days. And it is a proxy for STI incidents. And and if you are seeing more number of urethral discharge in the men coming to a particular STI clinic, in that area we need to strengthen our intervention, especially to the key population, so that the services can be improved. There is a possibility of untreated or hidden or partially treated infected individual there as a source happening. And urethral discharge in a PLHIV is a surrogate marker for incidence of STI and denotes changing sexual behavior of PLHIV community in that particular area. No, there is a reversal of the sexual behavior. That is a threat to the achievement what has been achieved by the program till now, and then presence of an infectious case, and there is the individual has not used the condom, and so this is the some of the important insights whenever we see the urethral discharge. Not only that, out of all the syndromes, urethral discharge syndrome in a male is more specific of an STI than the rest of all the syndromes. There is a possibility of the non-specificity associated with the rest of the syndrome, but with urethral discharge syndrome, we are 100% sure that it is nothing but of an STI. If there is a discharge visible, and there's a reason it is limited to the men. Okay, next slide, please. Now, as we have already discussed that we treat this with the kit 1, which contains azithromycin 1 gram plus cefixime 400 mg. To the extent possible, please administer them in the clinic in front of you to ensure 100% adherence. And then it also, if you don't treat properly the urethral discharge syndrome, there are so many complications can be seen in the infected individual. Some 30 years back, I have seen all these complications, but fortunately, we are not seeing them. And many of our colleagues are saying that they are also not seeing them. They are largely limited to the very poor areas and poor countries where there is no health services are not available or access is not there. Something like an epididymitis, periurethral abscess, urethral stricture, prostatitis, gonococcal urethritis, and then disseminated gonococcal infection, especially involving the multiple joints. Now, after administration of the kit 1, you have to advise the individual to come and see you on 3rd day after the treatment and on 7th day after the treatment, so that to ensure that the individual is completely cured. And secondly, please ensure wherever possible, partner treatment is ideal. And then as we have discussed, either we can administer the partner, we can motivate the partner to be brought into the clinic, or we can give the kit 1 to the individual index case with a request him or her to administer to the partner. And then in the period of this 1 week, it is ideal that the partner, the index case, should follow either abstain from the sex or use condom. And ideally, if it is possible, abstainism from the sex is the most very ideal thing. And secondly, the individual will have a dyspareunia. So even though he may have the desire to have sex, but it will be very, very painful for him because of the infection and inflammation of the glands in the anterior tract. Next, please. Now, cervical discharge syndrome, again, it is due to the gonococci and chlamydia, and followed by trichomonas, candidiasis, and sometimes bacterial vaginosis, and a million of other non-STI causing pathogens. There are more than 30 different microbes live in the micro universe of the vagina in a woman, and all of them will gain entry into the cervix whenever the cervix is inflamed and the arse is open. Otherwise, arse is usually closed by the cervical plug, which acts as a kind of a filter and does not allow any organism to enter. Now, clinical differentiation between the gonorrhea and Clycomedia trachomatis is very, very difficult, which is causing this cervical discharge. Because in all this, only thing, the difference what we say, though clinically, theoretically, it is possible, but it may not be, feasible, especially to the inexperienced or novice service provider by looking into the service through using the speculum. Now, if there is a what do you call, if the individual is a younger age, or if the individual has got multiple sexual partners, or if there is a new casual sexual partner in the last 3 months, and in the current sexual partner has a demonstrated STI, or there is the new partner or the existing partner started using condom, then we have to suspect probably the infection of the cervix could be due to any of the etiological etiological agents. Other than that, no, it is not possible. The trichomoniasis and candida is supposed to be giving the frothy discharge, and then cardiovide discharge, and then trichomoniasis will also give green frothy discharge. But these are largely theoretical. It all depends on the kind of a washing behavior of the individual, what kind of, if they come after douching her private parts to the OPD, you will not find any of these things. And there's still only the clinical suspicion based kind of a treatment presumption diagnosis need to be entertained. Next, please. Now, how do we treat this? Again, the kit one is the course what we give, consisting erythromycin 1 gram plus cefixime 400 mg. And similar like in urethral discharge, we administer this in front of us in the clinic itself, so that we are making sure that the 100% adherence was there. And then followed by we invite them to come for follow examinations on 3rd, 7th, and 14th day, and to make sure that the cervical inflammation has reduced and there is no discharge which is seen from the cervix. And then and partner treatment is advised. And again, like in urethral discharge syndrome, abstinenceism is very, very ideal. If not, correct and consistent use of the condom. And most importantly, let us not forget that whenever we are seeing a discharge, either from the urethra or from the cervix or anorectum or in the oropharynx, please don't forget to collect this swab and send for gonococcal isolation and testing for antimicrobial resistance. This is very, very important. This is currently available in all major medical colleges, and wherever there is the STA labs are there. There are about 56 of them across India, and any of these any of these STA labs has got capacities and capabilities to isolate gonococci and test their susceptibility to the antibiotics what we use in the program, and under the program called the GAST, Global Antimicrobial Gonococcal Antimicrobial Susceptibility Testing Program. This is connected to the WHO headquarters, and which tracks the susceptibility pattern of gonococci across the world with all the member countries. Next, please. Now, painful scrotal swelling. Painful scrotal swelling is a complication of poorly or improperly treated urethral discharge syndrome. That means, the possible etiological agents are gonococci and chlamydia. And, or it can also be due to other non-STI infections like TB, filariasis, pseudomonas. Mumps infection also can cause the, scrotal swelling. But again, the age factors and then other associated epidemiological factors need to be considered before you come to a diagnosis of the painful scrotal swelling. And most importantly, trauma. Nowadays, every kid is, so fan with the cricket ball hit to the scrotum without a scrotal guard is one of the major reasons for the scrotal swelling, which is also painful. And secondly, testicular torsion. This is again seen in the adolescent, and where the testis the testicle will be pulled up, and then the patient will be lying motionless, and he'll have excruciating pain when you try to touch the scrotum. And these are at the age. These are pointers for you to think of about the testicular torsion, which is also an important differential diagnosis for painful scrotal swelling as a complication of the untreated urethral discharge syndrome. Then as the age grows up, there is a possibility of the testicular tumors and the hernia and hydrocele can also will come into the picture of the differential diagnosis in the painful scotus setting. Next, please. Now, how do we treat? Again, the kit one is the savior for us with erythromycin cefixime. Then we can able to control, and then we have to emphasize the individual to come for a follow-up schedule on 7th and 14th day. And then if you are having a clinical suspicion or if there is a evidence that it is due to the STI pathogens, then we have to ensure the contact tracing and treatment of contacts is possible. And then till the symptoms comes down normally, we advise them to either absenteeism or use condoms. Next, please. Now, vaginal discharge syndrome. This is the most commonly reported syndrome across India. And then again, 1/5 of the OPD in the gynae OP departments is because of the lower reproductive tract discharges. And it can be cheesy white, that a greenish or a frothy or a mixed. There could be a smell. There could be staining of the undergarments. There could be itching around the genitalia, and there could be change in the color. And the treatment is kit 2. It consists of secretizole 1 gram, 2 tablets, statum. It has to be given under your observation in the clinic, followed by fluconazole 150 milligram single dose. And on follow-up, we need to encourage them to come on the 7th day. And partners are usually not required to be treated unless until you're demonstrated in a wet discharge the trichomoniasis. Then the partner has to be treated with secretizole. Otherwise, it is not required to treat the partner routinely. And we also treat the partner if there is a partner symptomatic, like for example, candida. And that is the thing. And secondly, usually when there is a bacterial vaginosis, there is a fishy odor and a malodor, and usually partner will stay away from the individual so that there is a limited chance of infection transmission. And then we also need to educate and counsel on personal hygiene, genital hygiene, and coital hygiene. It is most commonly, after the coitus, people don't wash their genitalia, and then so that is another reason where the stagnant semen may cause along with the other agents may cause infection to develop. Again, we advise absenteeism for or use condoms for a week following the treatment. Next, please. Non-herpetic genital ulcer. No, non-herpetic genital ulcer, it means that bacterial ulcer. Now, the reason why it has not been labeled as a bacterial genital ulcer is because we are not so sure that this genital ulcer is purely bacterial. There could be so many other organisms also can cause. And again, it is very difficult clinically to differentiate between a viral ulcer and a non-viral ulcer or a bacterial ulcer. So in such indications, programs suggest to treat both for bacterial as well as the viral ulcers. But for the sake of understanding, let us divide them into the bacterial ulcers or non-herpetic ulcers and viral ulcers or herpetic ulcers. Now, this is the commonest pathogens are Trypanosoma pallidum, Haemophilus ducrei, Klebsiella granulomatous, and Chlamydia trachomatis, SEARO variants type 1, type 2, type 3, which causes lymphogranuloma venereum. And then the syphilitic chancre is usually single painless ulcer. But remember, this painless it depends on how clean is the area, and if there is a secondary infection is there, then this will become also painful. And usually the base is indurated, but it can be atypical, especially in the PLHIV. And there is also a possibility of seeing multiple chancres mimicking chancroid. But the thing is, chancroid ulcers are very, very soft, or sometimes the chancroid ulcers can be very giant, especially in the HIV infected individual. So this kind of a confusion is there, which is not possible by inexperienced provider to identify and differentiate. And then then probably the dark ground microscopy will be of some use. But then one need to understand and have experience of utilizing the dark ground microscopy to demonstrate Trypanosoma pallidum. And then there is and again, most importantly, the whole discussion will initiate with the eliciting the history of the sexual exposure with a infected person or a risky sexual exposure. And in the case of no previous history of the vesicular eruption on the genitalia, then the possibility of chancroid, vesicular chancroid, can be thought of. And then, or we can combine the treatment, as we said earlier, both for viral as well as bacterial STI. And, then review after a week. And usually herpetic ulcers, are usually painful. They're multiple. And, there is a possibility of the recurrence. And the recurrence will increase more than 6 times in a year in HIV infected individuals. And also the ulcers becomes, much bigger, much wider. And, and the only thing is in between the vesicles, in between the ulcers, there is a healthy epithelium. That is the one thing which will differentiate these from other conditions. So, but then, this is a very granular level observation. Unless until the individual has been trained, it is not possible to identify these minute and minuscule lesions. Okay. There can be also itching. It depends on depending on the hygiene. Next, please. These are some of the photographs. What you can see these are bacterial ulcers. So it can be single or it can be multiple, and it can also cause occlusion of the prepuce leading to phimosis, and there could be enlarged lymph nodes. Next, please. Now the treatment, as we have discussed already, either kit 3 or kit 4. Ideally, it should be kit 3. Please don't be afraid. Anaphylaxis is very, very minimal. So kit 3 is always ideal and is the best thing. Kit 4 is next option. But remember that kit 4 should not be used in pregnant women and in MSM and TG population. Next, please. Now, a few lines about the syphilis in PLHIV. Now, the reason because, even though it is uncommon in PLHIV, there is unusual serological responses reported among the people living with HIV. Neurosyphilis should be considered in the differential diagnosis of PLHIV with a neurological manifestation. And then they should be evaluated clinically and serologically for treatment failure till 2 years following the adequate therapy. And remember that any treatment other than benzene penicillin is not a good practice in managing the syphilis. And ideally, you should give treatment with the crystalline penicillin and then followed by the benzene penicillin. And then CSF examination and for retreatment should be considered in persons where the non-treponemal test titers do not decrease fourfold over a period of 6 to 12 months. Non-treponemal test means RPR or VDRL test. If the titers are not coming down with adequate treponemal treatment, then there is a possibility of the retreatment or there is a treatment failure is considered and retreatment is attempted. Next, please. Now, herpetic genital ulcers, as we have said that a group of vesicles will be coming. In a primary attack, there will be prodromal symptoms, and then there will be an itching, and there could be burning. And in a PLHIV, these vesicles will rupture and form into superficial to deep ulcers, and sometimes they become a very wide ulcers also. So this is the genital ulcers. And then following that, without even exposure, there will be a recurrence. This recurrence can be minimal, 1 to 2 in a year to more than 12 to 15 times in a year, and depending on the immune status. Next, please. The treatment of choice is kit 5, and then it consists of 4 mg that needs to be given 3 times a day for 7 days. And then, as we said that if there is a recurrence of more than 6 in a year, then we subject the individual for suppressive therapy that can be given till the number of episodes comes down to less than 5 in a period of a year. Next, please. Now, follow-up treatment is on 7th and 14th day. And then secondly, partner treatment is advised even though herpes is STI, only if the partner is symptomatic. Otherwise, partner treatment is not required. Contact tracing and treatment is not required. But counseling and education of the individual about the chronicity of the condition and its worry, and otherwise it will cause a lot of mental agony. Next, please. Lower abdominal pain is a complication of untreated or poorly treated cervical discharge syndrome. It usually presents with a fever. There could be vaginal discharge. There could be irregularities in the menstruation period, leading to dysmenorrhea and dyspareunia. There can be a low backache because of the sacral lymph nodal adenopathy and their adherence to the sacrum that causes pulling sensation. And again, one important clinical sign is cervical motion tenderness. When you try to rock the cervix from left to right, the individual will have the pain. And again, it depends on the kind of inflammation and severity of the inflammation. Next, please. What is the treatment? We use the kit 6. It consists of the cefixime 400 mg, a single dose. It has to be administered in the clinic in front of you, followed by 2 weeks of metronidazole and doxycycline BD, and with a follow-up of 3rd, 7th, and 14th day, and then again on the 21st day, so that if the discomfort is not reduced or relieved at day 3, then the clinical diagnosis need to be reviewed. And partner treatment is offered, and and contact. Partner treatment is offered, and and whenever it is possible, either we can motivate the index patient to bring the partner, or we can hand over the treatment to the individual to administer. What treatment we give? We give kit 1. We don't give kit 6 to the male partner of the patient diagnosed with lower abdominal pain. Next, please. Inguinal BIVO. This is usually due to lymphogranuloma venereum, serovariant 1, 2, 3, and to chancroid, which is fortunately has almost declined significantly. Usually seen in the inguinal region, which may be painful. Sometimes the BIVOs may rupture and it will form a discharging sinus, and it is also associated with constitutional syndromes. Next, please. The treatment earlier we used to give kit 7. Nowadays we are based upon the experts' advice, we are giving the kit 1. And again, the reporting of the inguinal BIVO syndrome across the country is very, very minimal. We have a feeling that it is almost eliminated, but there is no evidence to prove this statement. The follow-up is on 7th, 14th, and 21st day. Next, please. Now, complications of the untreated STI, RTI are improperly, poorly treated. Now, in women, most importantly, miscarriage, ectopic pregnancy, and increased risk of cervical cancer due to HPV. And men, epididymitis, urethral stricture, and fistulae, rectal fistula and urethral fistula. Both men and women, infertility, increased risk of HIV transmission and or acquisition. And then it also if they are infected with syphilis, it can affect heart and brain, and disseminated gonococcal infection, and it is extremely rare. And most importantly, the next generation is getting to be infected with a neonatal syphilis or ophthalmia neonatorum. The available evidence suggests that in India, we are likely to be seeing 100,000 congenital syphilitic babies being born every year. But because of the poor surveillance, we have no evidence to prove whether this many people are being born or not. Next, please. Anogenital warts is a very important STI caused by the human papillomavirus. It can be seen in either in the urethral area, or anorethral area, or oral area, depending on the type of sexual behavior. And fortunately, this is usually painless unless until secondarily infected, and it looks like a cauliflower-like offering. And most importantly, in PLHIV, no specific treatment is required other than the ART. The moment you start the ART, most of these warts will disappear automatically, or otherwise we have to do a cauterization. Next, please. Now, if you see the picture in 2008, it is a PLHIV having multiple viral warts on both lower limbs, who disappeared by 2013 with a successful implementation of the antiretroviral therapy in the individual. Next, please. Now, the differential diagnosis from the condyloma lata of syphilis and molluscum contagiosum, and then the small warts will usually disappear. Larger warts, either we use a chemical cautery or the electrical cautery, depending on the thing. If there is a much larger and bigger, then there is a possibility of doing the surgical excision. Next, please. Now, we also need to counsel the patients with HPV that the HPV is very common. If it can spread to the genital contact during vaginal and anal sexual, and can also spread to oral contact, and then usually it clears spontaneously. Some may progress, and some may convert into pre-cancer and a cancer, and we lose almost all 50,000 women across the world every year due to HPV-induced cancers. And some countries have successfully eliminated HPV-induced cervical cancer, but in India still it is causing a significant morbidity and mortality. And there is a vaccines available to prevent HPV-related infections to occur, and ideally should be given during the adolescent period before they start the sexual activity. And it is not that there is no proof or evidence to say that beyond 26 years of age that the vaccines will not work, but they will work, and vaccines work not only in the cervical area, but also it will work to prevent the cancers and precancers in the anogenital area, anorectal area also. Next, please. Molluscum contagiosum is a pearly white lesions. Once upon a time, even now it is a HIV defining criteria, especially if you see a giant molluscum measuring more than 10 centimeters and seen on the face, and then they are usually multiple and they usually spread and doesn't cause much of a pain or discomfort unless until they are secondarily infected. And then the treatment is very easy. It can be done with a chemical cautery, or if it is a smaller one, you can also use a simple needle and then sterilize. And please make sure that the needle should be kept away from your face. Otherwise, the contents of the spill on your face, there is a possibility of you developing the molluscum after treating the individual. Next, please. Now, the ectoparasitic infections, pediculosis is one of the important one. We will see a small red papules with a tiny dental clot. Unless until you use a magnifying lens, it is not possible to the visible eye. That will be very, very small. And there could be a generalized or local urticaria. And if there is a secondary infection, there is a possibility of cellulitis and impetigo. The treatment is permethrin 1% cream applied all over the affected area and washed off after 10 minutes. And then retreatment is indicated after 7 days if still lice are there or eggs are observed. And then blood clothing and blood linen must be decontaminated by the client, should be washed and well dried. Sexual partner must also be treated along the same lines. Next, please. Now, scabies is very common, caused by the Sarcoptes scabies, and then severe pruritus is the most common symptom, usually worse at night, and then other members of the family are also affected. And sexual transmission to the partner is possible through close contact. And if there is a secondary infection, there is an eczematization urticaria. Treatment is with permethrin cream applied to all areas of the body below the neck and washed off after a day, ideally, but it can be done even after 8 to 12 hours also. Or Benzyl 25% lotion, but it will cause a lot of smell and it may not be liked by many of the individuals. Next, please. Now, the special instructions, what we need to do is we have to instruct the individual to disinfect the clothing or the bed linen. Family members and sexual partners also to be treated at the same time. Norwegian scabies or custard scabies is an important one, which requires treatment in a inpatient forum, not to be treated at the house, and it is easily treatable, and even in a PLHIV. And there are both oral medication as well as the parental medication. The ivermectin is the drug of choice, can be given orally, 200 microgram per kg single dose, and repeated after 2 weeks. But it also can be given parenterally, 0.01 milligram. That's about 0.3 milligram intramuscular injection. Once is enough, and sometimes it can be repeated after 3 weeks if still infection is continuing. Next, please. Now, the objectives of the STI RTI control and prevention program is interrupt the transmission of STI, early diagnosis and appropriate treatment, prevent complications and sequelae of the STI, prevent parent-to-child transmission of HIV and syphilis, and reduce the HIV infection risk and transmission risk. Next, please. Now, how do we achieve this? First and foremost, we create awareness and we promote early health-seeking behavior, and then following the standard syndromic case management protocols, ensuring compliance to treatment, management of contacts and treatment of partners, counseling for behavior change, condom demonstration, provision and promotion, clinical follow-up, and documentation and reporting. There's a patient-wise card. They need to be filled properly so that you will have a clarity about what is happening and what is the progress. Next, please. Condom promotion program, it is one of the key strategy. It is a barrier protection. As Puri sir has already said, condom not only prevent STIs and HIV, but also prevents pregnancy. That's number one. Number two, we also need to remember the limitations of the condom. Condom is not 100% effective, even if the one uses consistently and correctly. The very reason because sexual penetration will happen only with erect penis. That for that to happen, there should be a sexual erosion. During that time, there is some amount of discharge is seen from the urethra that may contain the pathogens. As a result, that may cause transmission of infection to others. And then these condoms are available freely and distributed at all the HIV service delivery facilities. And then along with that, lubricants also required, especially for MSM and TG, because they practice sex through the natural, not a natural orifice where there's a possibility of break is very, very high, and through that the entry of the pathogens also can be done. Okay, and then there is a lots of commercial condoms are also there. There's not much of a advantage between the commercial and then freely marketed one. But the only thing is we have to make sure that the condom are not being kept in a hot places, not to be kept in the back pockets and the inside the jackets. And if once the lubricant has been dried up, the condom breakage chances is very, very high. That nullifies the advantage of using the condom. And the access to the condoms should be made available to the key population so that they not have to carry them, then not have to buy. Second place. Next please. Now, role of the male circumcision in preventing HIV transmission. Most of you must have read lots of articles about this, and this has been widely practiced in the certain communities, and is also widely practiced in the African subcontinent. And it is it is proved that it reduces the spread of HIV infection. Now, why foreskin is more prone to HIV infection? It contains many of the HIV1 target cells, that is CD4 plus T cells, macrophages, and Langerhans cells. And these are closer to the epithelial surface and are the first to be infected with HIV. And the inner mucosal surface of the foreskin shows greater infectivity than that of the cervical tissue. As a result, removal of the foreskin supposed to be reducing the spread of HIV infection. And it is also proved in certain communities where it is traditionally practiced, where the infection levels are much lower than other. Next, please. Now, at this point of time, we also need to have one point. There is something called pre-exposure prophylaxis. Now, pre-exposure prophylaxis has been rolled out as one of the strategies by the National AIDS Control Organization last 1 year. It is now available through certain selected health facilities under the public health system through trained healthcare providers. Now, pre-exposure prophylaxis only helps to prevent sexual mode of transmission. It will not prevent STIs. It cannot prevent HIV, pregnancy and all. So even though an individual taking the pre-exposure prophylaxis, the individual need to be counseled, monitored, examined for a possible acquisition of the STIs. And so that usually the myth and myth concept is pre-exposure prophylaxis. If I'm taking, I'm safe from HIV, STI. There is no need to go and seek the service from the provider. So I want all of you to remember that pre-exposure prophylaxis is limited only to the sexual mode, and that means only about 90-94% of the HIV. And secondly, it has no role in preventing or acquiring or transmitting the other STIs other than the HIV. With this, I hand over to Sweta. Thank you very much for your patient listening. If there are any questions, please shoot them in the chat box. I will try to answer them.
Thank you so much.
Over to you, Sweta.
Yes, sir. Thank you so much. Kiran sir, can we please give mic access to everyone?
Done, ma'am.
Thank you. Participants are requested to please unmute mic and ask questions. Please feel free to ask questions. Yes, sir.
Can syphilis be transmitted by needle stick injury or some contaminated surgical instruments injury to medics and paramedics?
Yes, it is a possibility. Yes, it is a possibility. No, because see, HIV, syphilis, these are all the same STIs. Okay. Now the same modes of transmission of HIV also applies to the syphilis. But then the number of cases reported or acquired syphilis, there is a digital chancres. Once upon a time, when doctors used to examine the private parts without gloves, they used to develop chancre on their digitalia.
Sir,
so the number of cases, related or reported to be having by needle, the syphilitic cases acquired by needle is I don't think any reported cases are there. But then through blood transfusion, yes, there were syphilis cases.
Sir, can we in these cases give some prophylactic treatment for preventing syphilis?
Now, prophylactic, or what do you call, pre-exposure treatment for various STIs is advocated in India under the government only to the rape suspects.
And post-exposure
again, no, this
prophylaxis
is
for
rape.
syphilis.
Yeah, syphilis and other STIs also. And then, but again, no, it again varies from state to state. It depends on the state medico-legal norms. It is not widely practiced across by all the states in the country, but it is advised. In all Latin American countries,
Actually, my question is post-exposure exposure for syphilis. If we what treatment can be given?
No, post-exposure means how do we know that the individual has got the syphilis? So that is the reason when there is a rape victim, when we don't know whether the rape survivor who is exposed to the rape, what kind of STI pathogens have been entered, including HIV. So we routinely do for syphilis screening and HIV after counseling and testing. And in some states, there is also a practice of administration of the drugs to prevent possible emergence of the STIs, including syphilis.
Okay.
Yeah. Now, with reference to the quantum of the treponema in an individual following the entry of the treponema pallidum, it is there only theoretically, but it is not practiced widely and routinely because the treatment is very easy.
So
but very interesting question. Thank you
yeah.
very much. Yeah.
So there's one question in the chat box. Can you please once again explain the relationship between viral load of HIV and STIs?
Yeah. Can you please bring that slide? I think that's very important.
Sure. I'll do that.
Yeah.
Sir. So you'll have to guide me, sir.
Yeah. Go. Yeah. No, this one. Slide number 13. Yes. Yeah. Now, this slide will show us, what is the interaction between the STI and HIV. First, remember, HIV is also an STI. That's number one. Now, only thing is, the modes of transmission is also more or less same. The single most determinant for anyone to get either HIV or STI or both is their high-risk sexual behavior. When we say high-risk sexual behavior is a sex with the casual partners, sex without a condom, sex with an infected person, or when sex with a person with unknown status. Now, what it will do, it increases the risk of the acquiring HIV and STI. And if they are already having HIV, then the increase of the risk of the transmission will be more to others. The reason because HIV, we all know, it impairs the immunity, the body defense mechanism. Once the immunity has been altered, there is a altered natural history of the other STI, and also increases the susceptibility to acquire for other STIs. No, that is the first interaction. Secondly, these STIs can also lead to the HIV because if there is an ulcer, there is an opening of the epithelium, and through that, that means the defense is not there. The entry of the HIV becomes easy into the body. So that is another one. Thirdly, because of the impaired immunity, because the CD4 cells depletion, there is a rapid progression of the clinical disease from HIV infection to the HIV disease because of the increased viral load. As STIs stimulates immunoregulatory mechanism, the cytokine system, that it in turn stimulates the viral multiplication. So the virus number increases. And that as a result, the viral quantum increases. That means the viral load increases. And anybody with a high viral load is an efficient transmitter to the other. Did I answer your question, sir? Can you please unmute him and then ask?
Shahifa Anjum, ma'am. Can you please unmute?
Good afternoon, sir. Yes, sir, it is clear now.
Right. Now, the most important here, more than STI, what we need to remember is the TB. TB is one of the most potential catalyst of the HIV multiplication. It increases the HIV viral load to the extent of 7 to 10 times. That is the reason we don't see SEARO discordance in HIV TB infected individual with their spouse. Whereas with the STI and the HIV, we still see SEARO discordance, and because the viral elevation is not that great like in TB. And similarly, the death is also very, very high. The mortality rate is also very high in HIV TB in the absence of the effective treatment controlling both of them. And so if you want to reduce the AIDS as a public health problem, more emphasis should be placed on diagnosing and treating every case of TB in the society. Yes, please.
Any more questions? Participants are requested to type their questions in the chat box, or they can unmute their mic.
STA discharge contains high viral load of HIV. No, Kapoor ji, nahi hai, aisa nahi hai. STA discharge means, what do you mean by STA discharge? What we are saying is, in a HIV infected individual, the HIV virus, what we determine, what we assess in the, what do you call, in the blood, is not synonym with what we see in the genital mucosa and subgenital mucosa. There is a possibility of the HIV virus present in significant number, and that itself can cause the transmission risk to others.
So it's not the increased number of viral load in the STI discharge, like ulcer, urethral discharge won't be having high viral load of the HIV also. That increases the transmission of HIV in STI cases.
So what you are saying is, if there is a urethral discharge, in that discharge will there be HIV virus? That is what is your question?
Yes, yes.
Yeah, there will be, but then it is not sufficient per se. See, the point is, for why every HIV positive pregnant woman is not infecting all the children born to her? Why every HIV positive person is not transmitting the HIV to others? Again, it depends upon the quantum of the virus. There is certain cutoff threshold level. Unless until the virus quantity is beyond, up and beyond, the transmission risk is not there.
No, but
These are all the factors. The reason the U is equal to U and treatment as prevention concepts have emerged.
No, the reason I'm talking is, in case of STI, the transmission of HIV is about 10 times more.
Agree. The reason is, it is not one factor. The point is, when there is a genital ulcer, what will happen? The ulcer is causing a opening, a open wound. This open wound encourages the pathogen to entry, the gain entry. It did not have to do a kind of a trouble. No, Treponema pallidum, if you remember the images of Treponema pallidum, it looks like a screwdriver. It can penetrate intact skin and epithelium by burrowing itself. Unfortunately, HIV doesn't have that kind of a scope, that kind of a capacity to do that. So if there is an open wound, the entry of the pathogen is easy for them. And that is the main reason why STIs increase. Again, STIs, there are different varieties. There are discharges, there is ulcers, there is a combination, there are growths. So everything has got a different weight.
So that means receptive partner will have chance of HIV, not the penetrative partner, which is not true, sir. In the penetrative
Agreed.
partner,
See the here, but then the point here, as I said, there is something called a super infection. Now, if the penetrative partner is having a HIV, then he will give to the receptive partner. If the receptive partner is also having HIV, what will happen? Does it get infected to the penetrative partner or not?
should have, because load is very high.
So that super infection is there. That is, unfortunately, that is one factor in the HIV. So it is not limited only to the what do you call unilateral kind of a transmission. There is a possibility of the byway or bilateral transmission risk is there.
So that's the point I'm making. The chances of penetrative partner is also very high, even if he's not having ulcer.
Absolutely. Penetrative person.
So that is because viral load is high in that person who is receptive partner having an ulcer. His viral load will be very high. That's why penetrative partner may also get an HIV.
No, that's what I'm saying. If the penetrative partner has got an open sore, and if the receptive partner has got a high viral load in the genital secretion, let me explain. Then you can answer, or you tell me, then I will answer. Because if both of us speak, and nobody will able to understand.
I'm asking simple thing. Penetrative partner is having an ulcer.
Pardon? I didn't get you.
Penetrative partner is not having an ulcer.
Okay.
A receptive partner is having an ulcer and
right.
HIV and HIV
right.
also.
Right.
So is there an increased chance for penetrative partner?
That's what I'm saying. So we are saying that penetrative partner do not have ulcer, do not have HIV. The receptive partner has got ulcer, also has got HIV. As a result, theoretically, she will be, or he will be having, more or a high viral load. So is there a possibility of transmission of HIV on the STI entry into the penetrative partner? That is our question?
Yes, sir.
Okay. Yes, there is a possibility. Surely there is a possibility. If you all remember, no, in the initial period of the HIV surveillance, STI clinics used to be one of the sites for the measuring the HIV prevalence among the STI patients.
Yes, sir.
Now, what it used to be interpreted at those times was, 20% of the STI patients have got HIV. Now, people have not understood the natural history of the different STIs and HIV. Now, this is the 20% of individuals found to be having HIV along with other STI at that time of the surveillance period. Nobody knew when this HIV entered into that individual. No, subsequently, later lots of studies and everything, they gave a clarity on that particular thing. So now we all know that, in fact, nowadays, we don't even use STS sites as a surveillance sites. So there is a clarity, as we start understanding. See, the word AIDS itself has come because nobody knew what it is causing. Because as we know that there is an inherent immune deficiency syndromes, to differentiate that, we use the word acquired. Only subsequently, when we identified HIV, then we realized that it is a causative organism, and then subsequently we started calling HIV infection and HIV disease, and now AIDS is largely a kind of a public nomenclature, rather a scientific nomenclature. So as we progressed forward, we definitely learned a lot. But at the same time, my request to all of you is STIs are still a threat to the PLHIV community, especially the post-COVID. I am seeing emergence of syphilis in many parts of the country, and then probably you must be also seeing the same thing. Please make sure that every case of every patient who is coming to you gets screened both for syphilis and HIV, and especially the key population. And even if they don't identify as a key population, if the history gives you multiple sexual partners, then there is always a possibility to examine. And don't omit examination of genitalia, oropharynx, and rectum, irrespective whether the individual is coming to the STI clinic or not. I think now that is what is very, very essential and very important. And by and large, the national program prescribed treatment regimes are not showing any kind of a resistance so far across the country. So as long as they are working well, my sincere request to all of you is kindly utilize either color-coded kits if they are available, or the same constituents from the general pharmacy to treat all identified cases of STI and in RTI. That's very, very nice question, Mr. Kapoor. Dr. Sahab, आप कहाँ से?
Sir, I've been director of Delhi AIDS Control Society. I'm basically a pediatrician from Delhi.
Director of Delhi AIDS Control Society.
We have these heads. I was director, I was additional director. I worked in NACO also for the law.
Oh, Dr. Praveen is there?
Dr. Praveen is there. That is movement additional project director.
Right. Sorry, I haven't met you, sir. We did a program, pilot in Delhi. Thanks a lot for your support, the entire DSAC support. I hope you are joining us on 16th.
I'm joining on 16th. Definitely, I'm joining.
Yeah. Thank you. Thank you. Thanks a lot.
What are the drugs you're prescribing for pre-exposure, sir?
That's what pre-exposure prophylaxis is limited, state to state, and then because pre-exposure prophylaxis, what we routinely use PEP, in the needle stick injuries and all, and then in rape cases also it is being practiced in certain states, but not uniformly practiced across the country.
And that's a post-exposure, sir. I'm talking. Are you advocating for pre-exposure?
Pre-exposure prophylaxis is there, that ART is there, PrEP. But then that is limited only to certain public health facilities through certain healthcare providers, not available routinely because of associated other challenges with the PrEP. PrEP, if it is not carefully monitored and then supervised, it has got lots of untoward effects, especially syndromics. So this is it is nothing new, and we have seen this from many of the African countries. And this is one of the what you call contrarian arguments put forth before the NACO when the PrEP has been advised. But then still, it has been cautiously been rolled out by the NACO. That is a very, very good gesture at this point of time. But PrEP is required, but then PrEP should be used in a very careful way, not routinely used. And PrEP is only for the sexual mode of HIV, not for anything else.
That is good, sir.
There is also PrEP for the STIs, but then that has not been practiced in India.
But very high chance of misuse of this PrEP, sir. As people using emergency control pills and emergency contraceptive pills, people might start.
Yes, sir. Yeah, you're right. You're right, Dr. Kapoor. No, that is one of our worry. That is one of the reason, especially when we don't have HIV drug resistance studies, institutionalized manner. When PrEP is used without control, without monitoring, that will have a serious side effects. And that is the reason, NACO never advised outside the prescribed facilities. And there is not supposed to be purchased, but then people are telling that it is available online. Anybody can buy and use them, but that is not a useful. That's not a good sign.
Very good. Bad sign, sir. May develop resistance, sir. Very soon.
Yeah, that's true. That's true. Absolutely. Yeah. I think maybe once you come on the 16th, we can impress again on the NACO leadership, and then that can be done. Yeah. Right, sir. Thank you. Thanks a lot.
Thank you.
Any more questions from the participants?
Sir?
Yeah.
Hello. Can we measure this genital viral load?
Yes, there is, but it is in the research mode, not routinely available in the open system, that requires a special apparatus and special procedures. But it can be done. Institutes like NARI does that.
Okay, sir.
ICMR institutes also does. Yeah.
Okay, sir. Okay, thank you.
So can we quickly run the post test?
Yeah, please.
Thank you. Kiran sir, can we have the post test, please? The post test questions are now visible on your screen. Participants are requested to please attempt all the 4 questions. Kiran sir, we can stop the post test now. Answers to the questions. Which of the following statements about STI RTI is not true? Statement that is not true is all RTI can be said to be STI, but not all STI are RTI. Which treatment kit is used for treatment of urethral discharge? The treatment kit uses treatment kit 1 with follow-up on 3rd day and 7th day. A 38-year-old male PLHIV on ART since last 2 years, presents with swelling and pain in scrotum since 10 days with history of burning while passing urine. Patient complains of fever since 3 days. How will you manage this patient? The answer is use treatment kit 1, schedule follow-up on 7th day and 14th day, contact tracing and partner treatment wherever possible. Question number 4, treatment kit 5 is used for herpetic genital ulcer. Kiran sir, can we quickly run the feedback form? The feedback form is now visible on your screen. Please scroll through the questions. There are 4 questions in all and answer all the 4 questions. The next session is scheduled on Monday, that is 12th of September, and the topic is HIV and co-infections, hepatitis and leishmaniasis. Special NDLS is also being held on Tuesday, and the topic is phased out ARV drugs and transition to DTG-based regimens. Participants are requested to attend the NDLS on both the days, Monday and Tuesday. The NDLS is scheduled at 2 o'clock. Kiran sir, we can end the feedback poll now. I thank Dr. Puri sir for joining us for opening remarks. Thank you, Prasad sir, for this session. Thank you to all the participants for patient listening, and we are sorry for the technical glitches in between. So can we conclude the session?
Yeah. Thank you. Thanks a lot.
Yeah, thank you, sir. Thank you, sir.
Yeah.